This episode is all about CBCT and how it's being used in the upper cervical chiropractic office. Lots of good details, research that's going on, and a training coming up for chiropractors who want to learn about the analysis. So hope you enjoy. Welcome back, everyone, to the Upper Cervical Chiropractic Research Show. This is episode 32. On behalf of the Council on Upper Cervical Care, I am Dr. Kevin Leach, and here with me once again, Dr. Tyler Evans. How are you, sir?
Hello.
As enthusiastic hello. It's a good way to get things started here.
Yeah.
All right. So today's episode is all about CBCT. It's definitely something new in the upper cervical chiropractic realm. And upper cervical chiropractors have been using this technology for a little while now. And we're going to go over a few different papers regarding CBCT and its uses in the upper cervical chiropractor's office. Some research that should be released hopefully by the end of the year. And for upper cervical chiropractors interested in learning about CBCT use in their office, we're going to mention a training that Dr. Tyler Evans and a few others are putting on for analyzing the craniocervical junction with CBCT technology. So, Doc, before we go through, and start with each of the papers, do you have anything right off the bat that you want to mention or discuss, or should we just get right into Dr. Hollowell's paper?
Yeah, well, I think it is what's the word? It's one of those moments in time where it's maybe not a breaking point, but things are coming to a head with Conebeam CT and chiropractic to an extent. We're starting to get machines in schools. Life West by the end of the year should have a machine.
Nice.
And should be teaching Conebeam CT. And I say that because Dr. Ron Overseen has promised me now many times, and he will deliver. So
nice.
We're excited about that. So cool. Life West should have a machine and be teaching there at Life West in Hayward, California. And then Sherman Chiropractic College has a machine in there, putting it in their curriculum. Northwestern Chiropractic College up in, I believe it's Minnesota, has a machine. Thank you to Carrie Johnson.
Cool.
And it's been building over time here, and so we're working to build it into the profession from the inside out.
Awesome. And Dr. Hollowell's paper that we're about to mention here, isn't that the first one that really utilizes CBCT? Awesome. Cool. So that was back in 2013, and he was still in Italy, wasn't he?
I think maybe it was either in Italy or back in Brazil. I can't remember exactly which one, but
I can't remember the year either. I came back in November 2011, and I know he was still there, but I can't remember when he went from Italy to Brazil.
I think he was in Brazil. I think he was in Brazil at that point. At least that's what I remember. I could be wrong, but Jake, correct us, but fix us if we're wrong. But 2013, he did this paper, but I think he'd been using the technology for a little while. So maybe he did find it in Italy. I can't remember.
Okay.
But Jake graduated, I believe, in 2010, I believe. So he was using upper cervical chiropractic, Blair upper cervical chiropractic care for a year or two, stumbled across the technology because he was in a place, either Italy or Brazil, where they could not take x-rays. Chiropractors can't take x-rays. Both of those places, I believe, chiropractors can't take x-rays, so could be other one. But
it's definitely Italy. I don't know what Brazil.
Chiropractors can't take x-rays in Brazil either. So either way, one of the two. And he was sending patients to an imaging center, and the imaging center said, "Hey, look, we've got this really cool. You're trying to get 3D with your 3 x-ray or 5 x-ray view series that you're doing. That's really great, but why don't we just do a 3D Conebeam CT? It's a similar dose. You get better information, and it's better for everybody." And Jake was like, "Oh, okay." And so he just started playing.
He ran with it,
trying to figure out what worked best.
Yeah, totally.
So
totally took it
that developed into he took it ran with it. It developed into a great relationship, and then Jake kind of pioneered it for the Blair Society. Although Jeff Schulten had been talking about it since 2010-ish with, or even prior to that with Curtis Westerson up in Alberta, Canada. They kind of work hand in hand. He's a dentist. Curtis is a dentist. Cheers to you, Curtis. And then over in, where was Chris Chapman before he was in his spot now? I think he was in Idaho, possibly. Okay. But Chris Chapman had a practice where he was, maybe it's in Utah, but he now has a practice in Utah where he has a dentist. He has dentists working in his office using Conebeam CT, and he corrects the misalignment in the upper neck, and they use these scans to measure airway and stuff. And he was doing that in 2012. So Chris was kind of an island on his own. Jeff was an island on his own, and Jake was an island on his own. But Jake kind of got the word out more because he was, writing. He wrote this paper about it, and he was really utilizing it. So Jake was kind of the Blair pioneer that we all know. So
cool. Yeah. All right. So Dr. Hollowell's paper is it's Conebeam Computerized Tomography for Biomechanical Analysis. Biomechanical assessment of the Occipito-atlanto-axial articulation in a 75-year-old woman with migraines undergoing Blair technique by Jonathan. I always forget how to say his last name. Verderame. I thought it was Verderame, but. Sorry, Jonathan. And Jake Hollowell, obviously published in the Journal of Upper Cervical Chiropractic Research in 2013. So this was a case study. Migraines being helped with upper cervical care is nothing new to talk about with what it is that we do. However, this study was done to link using CBCT technology to attain Blair technique protocols instead of traditional radiography. So it appeared to be beneficial in the reduction of migraine symptoms in this 75-year-old. In this case, obviously, we have to say this case study is not conclusive for causation, but the association of Blair protocol and using CBCT and improvements of migraine symptoms warrants further investigation to association and improvements suggested in the case. So Dr. Evans, do you have any comments, or you already went through a little bit of Dr. Hollowell's background, but anything about, this real quick case study?
Yeah, so, it's a case study, just like you said. You can't draw any big conclusions from it, but it's data. It's a data point. Right. It is, it's a signal, right? Yeah. It's a small signal, but it's a signal. And so we're trying to clump these signals together. And what this shows is that, you have a 75-year-old female patient and she has migraines. You would be, as a medical professional, you would want to image the neck if there's a problem there. And 3D is the gold standard for care of the cervical spine, especially as Jake discusses the Occipito-atlanto-axial articulation, or the craniocervical junction. And I found out about Jake's work through Ian Bulow during the time that I was taking the Diplomate program from 2013 to 2015. And that Diplomate program is really what has, as a part of this, and the Blair Society and NUCA now is really pioneering it, and orthospinology are teaching this technology, but we have Jake to thank for. So, I think that this paper is a great signal for, hey, look, if you're going to be working in the upper neck, you need some good imaging, and 2D, trying to build a 3D image from it, is great, but if you can get 3D right away, that's a much better standard, and that should be the standard of care within chiropractic, honestly, if we're looking at the cervical spine. So
yeah, I feel like this paper, although again there's lots of variables, it says, hey, listen, we Blair practitioners use x-rays, radiographs to attain protocol, to attain listings, to adjust patients. We see lots of good results. But hey, listen, I used CBCT to attain the same protocol, same listings, and still had good results. So it's saying, hey, listen, I can use CBCT and not just radiographs in order to get, what I need. I feel like it's the paper saying that as well.
Yeah, absolutely. Yeah, cool. He's even got some dose considerations in here, right. But it's like, yeah, it's a big leap to start talking about dose in this paper when you're talking about patient care, because you can only pick like one lane that you want to really go down in terms of what you're trying to prove in a paper. And this is a case study,
Right.
And we can talk about the white paper that Dr. Michael Beebe and I made, and that paper is more about dose, but it's headed down that direction, so it's gold standard 3D lower dose, working in the neck. We want to take good images. So yeah.
Definitely exciting if it's even lower dose. I mean, we've been through all of all of that, but
right.
It's
good. I mean, it's good to hit it again and have that conversation,
Right. Totally. Cool. Yeah. Moving on, or anything else?
Yeah. No, I mean, okay. I think Jake did a great job.
Yeah.
And he got that first paper out there. We need more. We need more people doing these Conebeam CT papers so that we can start to build some data points so that we can start to talk more about this technology within chiropractic. Totally. I will just say, I am currently working with Alberta. I'm working with Michigan. I'm working with Ontario. Provinces and states. North Carolina is a state that I've been working with. California is a state that I've been working with, to not necessarily, it's the wording is expand scope, but the reality is Conebeam CT is just X-ray. It gets a misnomer that it's CT. It's not a CT. It's not computed tomography in terms of the algorithms that they use and the high dose that they use. And if we break it down, it is a form of X-ray. So it really should be within our scope, honestly. I know it's a different technology, but when it comes down to words on paper and legal documentation, the boards get picky. This is something that we're going to need more research on. And when we do that, when we have it taught in more schools, then the state boards and the provincial boards will start to recognize it more as a preferred imaging modality for chiropractic. So that's really why we're doing this. That's why we're talking about this. That's why we need more research.
Got it. Cool. And a big thanks to Jake. He probably doesn't get enough credit or praise for everything he's done and all the hard work he's put in. I'm sure he hasn't been reimbursed for any of it. So it's like a big thanks to him for kind of paving that way and just kind of being a pioneer for that. So big thanks to you, Jake.
Yeah, absolutely.
Yeah. All right. So moving on. So let's talk about the CBCT papers. So you provided 2 different papers, Conebeam CT of the head and neck, part 1, physical principles. And then the second one being Conebeam CT of the head and neck, part 2, clinical applications. Now this was put out in the American Journal of Neuroradiology. And you wanted to obviously go over these papers because it gives a good baseline about the CBCT technology for anybody who just wants to get a good baseline of, hey, this new technology and all the parameters inside of that. So I would like you, because I consider you and, obviously Jake and, inside the Blair community, you guys are the experts on CBCT as far as using it, analyzing it. So why don't you give us a quick overview of any points that you might think are important, especially how they relate to the craniocervical junction, the upper cervical spine, and how upper cervical chiropractors could benefit from using it.
Yeah, absolutely. So this is a good little transition from Jake's paper, which was in the chiropractic profession. We've started to adapt this technology for our clinical uses. We're going to take a step back and take more of a 30,000-foot view and just look down on the technology and see like what's been going on and who's using it and what's it being used for. So these 2 papers were produced in 2009 or published in 2009. They're a little bit old, but the dose considerations are pretty similar, and the technology hasn't changed too much. So all the basics are here. What's important to understand is Conebeam CT is not really new at this point. It actually developed in, I believe they say in the first paper here, around the year 2000 in Italy. So that would make sense if Jake started using it in Italy, because I believe that's where the technology kind of was birthed. And what it was developed for is for placement of implants and doing dental surgeries for dentists and placing, teeth, implants. So what is unique about it is back in the day, before 2000, what they were trying to do is replicate what a CT scanner can do with a lower dose, faster scan that, you can use on a regular basis to scan the teeth and get clear enough images that you can use these pre and post to see how your treatment has gone for dental surgery. So that was kind of the initial reason behind this, and they were curious. They were very careful with the dose. That's one of the reasons they came up with this technology, and I'll just go into that briefly. So to cover the dose consideration, there is a consideration that is important, right? So anything above 100 millisieverts is something you want to be careful with, and that is effective dose. So I think we've talked about this before, Dr. Leach, but effective dose, anything over 100 millisieverts is something you want to be careful, because it has been shown to cause issues in the human body, has been shown to be harmful. However, below 100 millisieverts, we have not seen harmful effects for the body. And that's where low dose imaging fits in, that being X-ray, Conebeam CT, and CT scans. So even when we're talking about a full body CT scan, we're talking about 10 millisieverts. So that's a tenth of 100, right? Millisieverts. Yeah, go ahead.
So when you say a full body CT scan, you're talking about the prior CT technology, not the Conebeam?
Not Conebeam CT.
Okay. Got it.
Yeah, even when we're talking about a CT scan, which is a constant fan beam that rotates around up to 300 to a few hundred times around the body to get the image that's stacked. It's like a layer cake, right? Where you're just having that constant beam, and that is a much higher dose of radiation. You get about 10 millisieverts for a full head to toe CT scan. Now, when we talk about the head and the neck, we do a CT scan of the head and the neck, not a Conebeam CT, a CT scan. That is roughly one sievert or 1 millisievert or 1,000 microsieverts. Okay, so we're going to switch to microsieverts because we're talking about such small doses that we need to then lower our decimal points, move it 3 places so that we can talk about Conebeam CT and X-ray, right? So now we're talking about Conebeam CT and X-ray get somewhere between 150 to 100 to maybe 250 microsieverts per scan or cervical spine X-ray series. So for like a 2 or 3 to 5U X-ray series, depending on what you do. Laterals, you go through the neck, there's a lower dose. If you go through the skull, there's a higher dose because you got to shoot through the skull. It's a thicker bone. So when you take all that into account, you are looking at a dose that basically, so if you live on the level of the, like on the ocean, what's that called? Sea level.
Sea level.
If you live at sea level, on the level of the ocean, if you live at sea level, yeah. So if you live at sea level, roughly on average in America, you get about 5 to 10 microsieverts per day, right? And so one of these Conebeam CTs that I do in this room right next door, the scan that we do produces 50 to 100 microsieverts for a scan. That's 5 to 10 days of background radiation. That is a very small dose. So like we said before, 100 millisieverts is the minimal amount to cause harm to the body. We're talking about a tiny amount, right? And so bananas, they're radioactive. Your concrete and brick house is radioactive. The stars, the sun, the earth is radioactive. Everything's radioactive to an extent. Some things are inert, but most things have radioactivity to them. Right. And it's just a numbers game. So we've been taught to have radiophobia. That is harmful because when it comes to working in the cervical spine, we need good imaging, and you need, diagnostic imaging. So anyways, to bring that back full circle here, when we talk about fundamentals of Conebeam CT, we are talking about this range, this relative range of roughly 50 to 250 microsieverts. So that way you have an understanding of what that is. And I believe if you live in Colorado, you get almost double what the normal person gets per year, which is normally the person on average in America gets 2.4 millisieverts per year, which is like 2 to 3 CT scans of the head or the neck, right? Because I said it's about 1 millisievert. Right. So that's just living like on that average area in America. But if you live in Colorado, you get double that. And they are not evacuating Colorado at this moment for harmful effects. So
we should check.
Yeah. Wait, should we? Yeah, check the internet. Google it. It might be happening. But yeah. So you get my point. Is that a CBCT scan or an X-ray or even an X-ray series or even a CT scan, but we're talking even a quarter of what a CT scan would be or less for what we do. Right. And that is a safe procedure. That is a very effective diagnostic procedure. And the first paper, Head and Neck, Part 1, Physical Principles, goes through the Hounsfield, Dr. Hounsfield, who came up in 1967 with the CT algorithm, how they make the CT scanners work. And then it goes into how a CBCT scanner is different. And we have what's called a cone beam versus a fan beam, which is what the CT scans are, right? And so what's interesting about cone beam CT is it goes around one time or maybe twice. Like our machine goes around once down low and then once up high, and it stitches the two together. It takes less than a minute. These other CT scanners, they take quite a while. It's a much larger procedure. Whereas the cone beam CT, I can literally stand 6 feet away, push the button, and there's literally no dose that comes to me 6 feet away, because there's a 90% drop off outside of that primary beam that comes out of the tube and then goes to the sensor on the other side, goes through the patient and hits the sensor. By the time it gets to that sensor, 90% of it is gone. It's nearly gone. So whatever is left, it just dissipates within a foot of the machine. And then by the time you're 6 feet away, you're completely fine. They don't even lead line. They don't want you to lead line the walls for 48 of the states. They don't require lead lining. It plugs into the wall. You just plug it in. It's 110, I think, is what plugging in into the wall is, versus a big, what do they call it? A converter, transformer, or whatever the big X-ray machines have. So it's a lot, it's a lot different technology.
Totally.
So there's a lot of those technological kind of breakdowns in this paper. It talks a little bit about image quality. So with cone beam CT, you get what's called a voxel versus a pixel. So when you take an X-ray, you get a X over Y, right? Like X, Y. Whereas with a voxel, you get Z, right? So we're like that, right? So what's cool about that is you get depth, you get height, you get width, and it builds this data column from all of the images being stitched together while it goes around you in time. So it's just fascinating technology, and it's a better modality than X-ray. And I'm not picking on docs that use X-ray. I think X-ray is very important.
Yeah, it's a newer technology. Not everybody has it, period. It's like, it's understandable.
Yeah,
what is, just real quick, sorry to interrupt, what are the costs of the new systems?
Yeah, perfect. So that's a great question, actually. So I actually work with a handful of companies. So, if you are fresh out of school and you're looking to save some money, there are ways you can get machines for roughly between $30,000 to $40,000. I don't recommend it because the support is really not good. And most of the doctors that do that now, they regret it. We just had a doc the other day that I just got a message from her the other day that she was saying she really regretted it, because now we have a company through Chris Thornburg, Encompass Dental Solutions in Atlanta. He travels all around the country, and he comes to upper cervical chiropractors, brings them their iCat Conebeam CT machine, which is a really solid machine. They've really been time tested. They are durable. They don't break down. And if they do, Chris has parts for years, and he really supports people. So that is a really valuable service. And he charges right around $55,000 for a full field of view. It basically gets right above the ear down to about C7. So for the orthogonal docs, you're missing the top of the head, but you're getting really close.
Yeah.
And if for the orthogonal docs, and you really need that, if you've been in practice for a while and you really need that full field of view, the Viso machine that Telavir sells now through Plan Med in Finland. Telavir is our American company. They are producing this Viso machine that gets a 30 by 30 field of view. I mean, the thing is massive. It gets a perfect view of the head and the whole neck. And it does that, which we will talk about in the white paper that Dr. Beebe and I just sent to the peer review last weekend, because that's the data set that we got is from that machine, because it's the one we put in Sherman, and we're putting in all the chiropractic colleges. So yeah, that machine is a little more expensive. It's $125 for that machine, up to $130. Yep.
So for the most part, you have two recommendations, right? So you have the one that's 55. You said 55 and one.
Yeah, there's the 55, and that's with great support. You're never going to be left out in the cold with that one. And then the Viso machine is about double.
Okay.
Yep.
And so. You want to just touch on again what like the considerations would be for both of them? I think is it pretty much just field of view? Is it analyzing
field of
software?
view and use. So the iCat machines are used. So the $55,000 machine,
Got it.
It used to be $100,000, but now they're half price because they're used. But they
still have great support and a warranty of some sort. I imagine.
Warranty.
Okay.
You're covered. Yeah. Okay. And Chris literally flies out to people. He almost won't even accept. If somebody's got like a really broken old one and they want to have Chris work on it to become a client, like some people have these older iCat machines that we first bought from this other company. I'm not even going to get into that, but it's politics. But Chris, he like is very careful not to take on clients that he can't support 100%, because he doesn't want to like give the old bait and switch. So if he can't help you, he's like, hey, look, just buy a new one and I'll 100% support everything on it. Just throw that old hunk of junk out and get a new one. He goes above and beyond. I have to like praise him, because he donates back to the Blair Society every machine that someone purchases.
Nice.
He hires me to teach analysis with CareStream software after they purchase the machine. So I have a conflict there where I do get reimbursed for that, but it's amazing. I mean, he really gives back, and he's at all of our conferences. He comes to the ICA Council on Upper Cervical Care conferences and the Blair Society, and and so does Telavir. And Telavir, they're doing amazing work. And with Telavir, we're actually creating a first of its kind, one-click 3D. So everything else has been 2D analysis within Conebeam CT, because there's still 2D, there-ish 3D that you can do, but we are transitioning to straight 3D analysis for orthogonal and articular techniques right now with Telavir. So
now with that Viso, meaning like there's like upper cervical software, like that will you can plot lines and all that stuff.
Well, it's both. So you literally have the ability to click a button, run the protocol, and it will analyze in NUCA, orthospinalogy, Epic, AO, Blair, the whole thing, and give you all your listings and all your calculations. And then you can go back in if you want, and you can do manual calculations as well.
Right. And tweak things in case they didn't. Yeah. Wow.
Yeah, it's incredible.
That's wow. Like it knows what points to pick.
Dude, it's been a battle, but it's incredible.
That's awesome, man.
We've got the best minds working on it. It's not my mind being the one that's come up with the analysis stuff, because I'm not there yet. But guys like Josh Silver and James Beadle and let's see who else has been on it. There's Bo Rochester and gosh, what's the NUCA doc that developed the first set of software? Ben Kuhn, but then the guy before him that does all he does the certifications for NUCA. Gosh, what's his name?
Zabellin?
He teaches at Zabellin. Michael Zabellin. Yeah, Zabellin. So we've got some great minds on this stuff. It's been really cool.
Cool.
So, yeah.
Cool. Anything to go in? I mean, we could probably spend 3 days going through these two papers, but it's,
the thing to know, I think the thing to know is just that the first paper is how the machine works. The second paper is what do we see on the Conebeam CTs. And with that second paper, this is a dental technology, right? So the past 20 years has been all teeth and jaw and airway, which is fantastic. And, that airway stuff is cutting edge. That's going to be a big thing for us within chiropractic. If we can prove that, the science shows when we correct the upper neck, it opens the airway below, which we know it does. That is a life altering treatment. That's a modality that's going to add years to life there as you increase oxygen flow to the brain, to the body. Bam, that's like a huge data point, right? So we just have to follow that rabbit trail wherever that takes us over the next 10 years and keep doing that research. And then, a lot of the other stuff, which is important to know, is that when you do a Conebeam CT scan, if someone does a Conebeam CT scan, you really should have them read by a radiologist, one that knows the teeth and the jaw, because most of the pathology actually shows up in the mouth. And that makes sense. People have cysts, they have dental issues, they have things there. So you need to have somebody reading the sinuses, the inner ear, the teeth. I had a woman just the other day that she came in for shoulder pain, headaches, and neck pain. I just did her 8-week re-exam or consultation yesterday, and she said she's 95% better, which is amazing. However, when I did her scan, Matthew Richardson down in Palmer, Florida, high five to Matt. He's our DAC bar that we use. He's amazing. He reads Conebeam CTs for chiropractors, but he found a benign hemangioma up in her skull. And I would not have seen it on x-ray because it was so light. It was so tiny, but it was in 3D, so he could see it. And I couldn't even really see it, but he found it, and she went and got an MRI. And that's a cool referral opportunity, like, hey, look, I'm an upper cervical chiropractor in my community. That woman's a nurse at the hospital. So now the hospital knows that we're doing state-of-the-art care. We are helping people because she got better, and we found something that may not have ever been found, and she was fine. It's benign, but heck, what if it wasn't?
Are there a list of several DAC bars that do actually read these, like when you send them off to? Yeah. Okay.
So Matthew Richardson, he's kind of limited anymore because he's kind of tapped out on all of the people that he can read for. But Cliff Tao, he's got a big group of people that he can read for. Good. And he's over in California.
Yeah. I use Cliff.
And there's a handful of other people, but they're really kind of more hit and miss. So I rely heavily on Cliff and Matthew Richardson. And that's why we need to do this video, is because we need more radiologists reading this stuff. And I just had a conversation with the radiology department at Life West a couple of weeks ago, and that was a very fruitful conversation. Hopefully many things will come from it, but one of them being that they're interested in teaching it. They're interested in getting more involved as DAC bars. So I'm not going to name names there, but the radiology departments at schools, if we can get them, like at Palmer, Ian McLean, I think, is the gentleman who's the head of radiology there. If we can get him involved, if we can get more of the radiologists at the schools involved, then this builds momentum. So we need that.
I am smiling because when I was at Palmer,
Yep.
It's Iowa's, the winters are just brutal, right? And so I lived like on a hill. One of my, I think probably during the first year, and I slipped, and I like rolled my ankle or something, and so I went and had it X-rayed, and I still remember him walking in the room, kind of like, he loves what he does.
Yeah.
When he like the way somebody acts, you can just tell. And he comes in and he goes, "You had a stress fracture in your shin, didn't you?" I had it in high school in my right shin. You know what I mean? And I was like, yeah, like, how did you, oh, okay. Yeah. I guess they would have seen it. They would have seen like the little, yeah. So
that's hilarious.
Anyway. Yeah.
No, it's great. Yeah. And that's it, man. I mean, these like, as fired up as they are about radiology for x-rays, we need them fired up about Conebeam CT the same way. And maybe it'll be the next generation, but we've got to try. We've got to start talking with them, getting connected.
That's what we're doing. Cool.
Yep. Perfect.
Awesome. Move on to the white paper.
Yeah, for sure. Well, white paper. So, okay. So Dr. Beebe and I just worked with Northwestern Health Sciences University, Dr. Greg Denuzio. He was the head of the clinic up there, clinic lead. And what happened was, I'll just say it this way. Dr. Carrie Johnson got us connected via a situation where they got a machine in the school, and there was a promise that there would be a paper that would come out of it. And so this paper is a result of that. So thank you, Carrie Johnson. Thank you, Greg Denuzio. And I had already done kind of the yeoman's work on making the skeleton of the paper, but it needed bones, or it needed meat on the bones, and so that's where Michael came in, Greg came in, and they updated a lot of my citations and really made it nice and clean. And Carrie actually gave us some good images. So anyways, the objective of the paper was to distinguish between the detail. So here, the title of the paper is Craniocervical Junction Visualization and Radiation Dose Consideration Utilizing Conebeam CT in an Upper Cervical Chiropractic Clinical Setting. Woo, lots of words there. But we got tons of great people involved. We got Greg Denuzio from Northwestern. It's myself and my wife, Dr. Beebe, and then Jamie Browning from Sherman Chiropractic College. She's the head of IRB there. So that's really helppful. And then Juha Kovitso in Finland and Helsinki. He's the Department of Physics researcher for the Viso machine, which is the machine that we use to get the data. And I was like, hey guys, if we're going to do a paper, we need the raw data from your dose considerations for the head and the neck of, said patients. And we're going to apply that to what it would be equivalent to X-ray. So cool. Objectives were to distinguish between the detail obtained on a Conebeam CT scan versus radiography. Basically, conclusions: the use of CBCT for visualization of the CCJ and cervical spine in the chiropractic clinical setting allows for superior visualization of the osseous structures. Further, with CBCT, the effective dose to the patient is equal or less than similar imaging protocols utilizing radiographs to evaluate the CCJ. So within the paper, we then got the data set from the Viso machine, and it's fantastic. It's in the paper there. It's got this graph where I believe we have, so if we have like a medium-sized patient, we do 100 kV, which, I think like if you're shooting regular x-rays, you're doing somewhere in 100 to 120, maybe 160 kV, depending on the x-ray, right?
Yeah.
Roughly.
Yeah. And but then it depends on the machine too. It depends on the tube. It depends on a lot of stuff.
Right. And then the MA is the time, and I think it's the energy I think the energy is the kV, but it's the time. And that is, is then calculated out. And then we have the microsieverts on the other side. So it goes somewhere between 48 for a medium-sized person. It goes somewhere between 48 microsieverts up to 120 for a medium-sized person. And that's amazing, because what we calculated from this paper is that with a similar X-ray series, you get a very similar dose. I believe it was roughly, this in comparison to, okay, common 5 image series taken in the upper cervical chiropractic protocol would have a total dose of 200 microsieverts, roughly. So we're in that ballpark, right? So we're either at the same dose consideration of a 3 to 5 view X-ray series, or we're at a lower dose consideration. So that's awesome.
That's awesome, man.
3D.
So,
getting 3D.
It's cool, man. So, I mean, pretty much it was the the paper's objective is dose consideration, right? Between radiographs and CBCT. Cool.
Yeah.
And you said that'll be in the journal
dose response.
Cool.
Yeah.
One of your faves.
I like it.
We know. We know. Anyone who watches this show.
Yeah.
We know. Awesome. Cool. Yeah. So, and then you think that might be out by the end of the year?
Yeah. That's the goal, is if we can have that published by the end of the year, that's where we're headed.
Cool. All right. Anything else with that?
No, I mean, I think that kind of wraps that up, and to transition then, just talking about the course, right?
Of course. So you've got a course coming up to go over how to analyze CBCT. I guess there's lots of different details and questions on that. So I'm just going to give you the floor to talk about, what you guys are going to do, when it is and all that. And you sent me the little advert, so I'll put that up here.
Yeah.
Maybe link to it. It's probably on the Blair. It's probably on the Blair site, right?
Yep. So the link, I can send it to you, but there's a link on the Blair events technique page. And yeah, so
you sent me the link, so I've got it there. BlairTechnique.com/events, followed by about 150 random numbers and letters.
Oh geez. Oh, sorry.
No, it's fine. It's a link, like whatever.
Yeah. Okay, so this course is different than what we've done in the past. In the past, Jake Hollowell has taught analysis with the CareStream software, and that is fantastic. We've needed that. However, this is a first of its kind, where we are having a dental radiologist teach how to read Conebeam CT for the chiropractic practice. So, when we're in school, we learn how to read X-rays for the chiropractor, right? We learn to read the issues and problems in the head and the neck and the abdomen and the lower back and the legs, and the knees and the feet, all those things. So we haven't done that yet with Conebeam CT, because it's not in the curriculum, or at least it wasn't up until now. So for those chiropractors who are out there practicing now, it is very important for you to educate yourself. If you're going to be taking on this new technology, you need to at least be getting some CE credits in how to read the scans that you're taking, and let alone you should be referring out at least some of the time when you have difficult cases. But this course, like I said, is a first of its kind. It's a dental radiologist. She is a world-renowned radiologist that teaches in Egypt and Europe and Russia and all over the world. And she's been highly recommended by Mr. Thornburg, Chris Thornburg. Actually, he connected us with her. And she in the past has worked for dentists only, but she has a very functional perspective. So she looks at airway, she looks at the cranial sutures, she looks at the jaw, she looks at everything, and has like this almost osteopathic physical therapy perspective, because that's her background. But she is a dentist. She's a dental radiologist. So, but she's just done a lot of courses with other people on how the structure can affect physiology, which is what we do as chiropractors, right? We look at structure and how it affects how the body works. So that's her love. That's what she loves to do, and she's very good at it. So what we will have are 16 hours of CE taught by her on how to read the airway, the teeth, the jaw, the sinuses, the inner ear, and then some the head and the neck. However, The last 2 hours will be taught, hour 17 and 18 will be taught by myself and Randy Kulig, who I teach the articular section of how to analyze for an hour. And then Randy will be teaching the orthogonal, how to analyze, for an hour. And I think that's important. If we're getting people, into this course, they probably want to know a little bit about how to use the software and how to use the technology to find listings. So we tack that on the back end, but the majority of it will be how to read for pathology, which is really important. And that will then show, for those people that are in like Ontario, and those people that are in Alberta and these other states that we're working on getting scope expanded, that it will give you CE credits to then go to your board and say, hey, look, I've been trained on this. When they come to you and say, well, you don't have any training, it's not within your scope, you just say, well, I have training and I have this dental radiologist that backs me up and I work with her often, and you have the ammo in your tool belt, right? So that's kind of why we're doing it. There's online links, like you said, at the Blair Events Technique or Blair Technique Events page. And we are starting the course on April 23rd. It's for 4 hours from 9 to 2 on, there's a little lunch break, 9 to 2 on Saturday, and then 9 to 2 on Sunday. And then we take a week break. So the next week, there's nothing happening. And then May 7th and 8th, we do another 4 hours on Saturday and 4 hours on Sunday. And
that's Eastern.
Yes, Eastern time. Sorry. Yep. Eastern time, 9 to 2 Eastern time. Yep.
So that's an early morning for West Coasters.
It is. Yep.
On a Saturday morning.
I know. And Sunday.
Yeah.
And Sunday. Yeah.
Yeah. Okay. Anything else? Pricing $1,600 if you register
pricing
by
$1,600.
April.
Yep, if you sign up by April 1st, and then after April 1st, it's $2,000 for the fee for signing up after April 1st and after.
Right.
So, and it is accredited through Sherman Chiropractic College. Yeah. So it does give you chiropractic CE credits, which again, this is the first time that we've done this. And this is a collaboration between the Council on Upper Cervical Care, the ICA's Council on Upper Cervical Care, and the Blair Chiropractic Society. So
got it. And so since it's through Sherman, it means every state would accept it.
I'm working on getting every state.
Okay.
I'm working on Alberta right now. They're being a little picky, but at least we'll have, the majority of them are already pre-approved. So I am working on every state as tricky as that may be. We're trying to get every state. So
cool.
Yeah. So if you have a question, if someone has a state and they're like, hey, do I get CE in my state? Just message me. I'll figure it out and we'll make it work for you.
Sounds good. All right. Anything
Awesome.
else? Anything to conclude or talk about just with CBCT and upper cervical and everything happening? Anything that you might want to touch on?
I mean, I think we covered a lot. So Disior is the software that we're working on through the council and through the Viso machine, that one-click software. That's going to be amazing. That's going to be, literally practice changing. We talked about getting schools on board, doing research. These are all the things that we need. We need to get radiologists on board. So if you are using the technology, refer out to a radiologist, because the more of them that you connect with, we were talking about it last night on the council call. Jeff was talking about Matthew Richardson saying that Matt just said that he needs reps. He needs more reps, right? So like it's practice. So, we got to practice this stuff. We got to get it out there in the field. And the more we do it, the more it becomes normal and standard. And that's what we want.
Awesome. All right. Well, on behalf of the Council on Upper Cervical Care, thank you all for watching, and let us know if you have any questions, comments in the section below, or reach out on social media, and we'll get back to you. Thanks for everything, Doc. We'll see you next time.
Awesome.
Awesome. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care and take care of your spine. It's the only one you'll ever have.